Welcome back. Now that we have talked about what gestational hypertension or the disorder is and how it progresses, some of the pathophysiology that we believe is behind the disorder, risk factors, manifestations, how it presents itself. Let's talk about like basic nursing care because that's super important, right? I mean, here we are caring for this client. We've identified the at risk client. We've seen the manifestations. We understand what's happening. What are we going to do for them? So you'll find this information on slide 28. And you'll see there on the slide that all nursing care is directed at assessment for progression. Is the woman moving from simply a gestational hypertensive disorder to a preeclamptic, mild, severe, and eclamptic? And we want to prevent the progression of that by close surveillance. So we're going to monitor that blood pressure, perhaps give those antihypertensive medications. So, and I know you've had antihypertensive medications in both your pharmacology class and in your fundamentals class. So you should refamiliarize yourself with those as to what their actions and side effects are. Perhaps she progresses that we need to administer magnesium sulfate. So we need to understand how we administer magnesium sulfate. Usually it's a loading bolus dose, and then they get a continuous infusion. And the things that go along with the use of that. We want to pay attention to their nutrition because we know that they're at risk for great fluid shifts. They do need to pay attention to their I's and O's. So intake, looking at a low sodium diet would be beneficial for them, and still maintaining all the wonderful things that we're going to learn about normal nutrition and pregnancy. They'll be on daily weights, strict INOs. These folks we're going to measure every bit of fluid that goes in and every bit of fluid that goes out. If she ends up on magnesium sulfate, it's likely that she'll have an indwelling catheter because the relaxation effect on the musculature throughout the body, smooth muscle in particular, oftentimes she doesn't have the ability to avoid conditionally. So indwelling catheters are usually used for someone who's going to be on a mag infusion. Reflexes, right? All those neuros. Is she having a headache? Does she have spotty vision? Clonus, assessing for clonus, all of those neurological signs. We're also going to be looking at that fetus because if mom is showing us signs and symptoms from her disorder, it is quite possible that the changes in her body are interrupting adequate blood flow to that almighty placenta. So is the baby now having repercussions from that as well? So ultrasounds, frequent ultrasounds, just to look at maybe even a biophysical profile. NSTs, right? They give us great information about how that baby's responding to its environment, those good accelerations that we see, up 15 beats per minute for at least 15 seconds. They're responding sympathetically. They are still intact. Kick counts, fetal movement, has there been graphic changes in that? It is likely if the woman is progressing to severe preeclampsia that the medical team will ask that she go on bed rest. No work, she's not going to be out and about anymore. And if she is on bed rest, of course, left lateral position because we want to prevent that inferior vena cava compression when she's on her back. Again, if she's admitted and we're observing her, she should be on seizure precautions. If she is moving towards severe preeclampsia, we know where that can go. And remember all those things about seizure precautions that you may have learned in the past. So she should be in a private room, decrease stimulation, not minimize the noise and the commotion. Ironically, we keep her close to the nurse's station because we want to keep a close eye on her. I find as an old practitioner, nurse's stations can be quite loud. So we should be mindful of that, right? So we be close to the nurse's station, but keeping that noise level down, the lights, not interrupting her constantly, not a steady flow of visitors. This woman needs rest. She needs decreased stimulation on her left side, perhaps padded bed reels, bed always in low position. those kinds of things. And we're going to continue to monitor her labs, her liver function, her renal function, her CBC, to look what her RBCs look like and what her platelets look like in particular, and any evidence that she might be entering DIC. The last topic for us before we leave gestational hypertension is just to understand magnesium sulfate, because it's the drug of this lecture. It really is. And it's kind of one of the classic drugs you have to know. You leave an OB course, you know you're going to have had a conversation about Pitocin. You know you're going to have had a conversation about magnesium sulfate. So magnesium sulfate, again, the two reasons that the primary reason we're giving it is to change that threshold for seizure activity. So we're giving it to basically impact the central nervous system. But we also know that there is a second impact it has, and that's on smooth muscle contraction. So if you think about smooth muscle throughout the body, right away when I say to you, if I'm giving a medication that can actually relax and decrease the synaptic activity in a smooth muscle, what else could it impact? The biggest thing that we worry about is respiratory. If the mom's levels get too high, then we have to monitor her for respiratory depression, because those intercostals and diaphragm can be impacted by magnesium sulfate. So it's a pretty high risk drug when we give it. There is an antidote for it if we felt as though the labs or her signs, we don't always wait for a lab. Sometimes it's just the signs and symptoms that tell us it's too much. We'll always have calcium gluconate on hand when we're using it. So because of its high-risk nature, we always have 2 licenses checking the dosing for magnesium sulfate. It should always be run on an IV pump. We should be doing frequent vital signs with respiratory specific assessment to the respiratory rate, quality of breathing. Is she moving air to the bases of her lungs? So good lung sounds, because it doesn't do us much good if we're not moving air down to those alveoli. We also want to be looking at her neuro. You know, sometimes if her mag levels are becoming too high, then we might see that her neuro just flattens right out. So here's a woman who had hyperreflexic activity. We were getting, +3, +4 on our patella reflexes when we assessed them. And then we go in now 6 hours later, and I'm having difficulty eliciting any kind of patella reflex, like one, maybe none. That's a problem. Maybe she's over-medicated. Maybe this is just too much, this dose for her. So we're going to pay close attention to her neuroactivity, because the indicators of whether there's too much med on board can impact the neurological activity, the clonus, things like that we've been assessing for sure. And we're going to do that at least every 2 to 4 hours, more frequently if her condition monitors. Continuously monitoring that fetal heart rate. That baby is going to have frequent fetal heart rate monitoring right alongside mom. So if we're in there every 2 hours with mom, we're going to be checking that baby frequently, because, again, the magnesium sulfate is also is dosing the baby as well, smooth muscle. So we want to make sure that the baby's tolerating this medication as it moves through its circulatory system for sure. Fluid restriction, typically we wouldn't want mom to get any more than 125 mLs combined per hour because of her status, and we're going to look at that urinary output. So signs of toxicity, of MAG toxicity, would be the absence of DTRs, deep tendon reflexes, urinary output that decreases to less than 30 mLs per hour. Could also be an indicator that she has MAG toxicity. Her respiration's falling below normal, which is 12 breaths per minute. Change in level of consciousness. So women on magnesium sulfate, even if they're not toxic, they're at the therapeutic range of their mag sulfate. They can seem tired and a little sluggish. That's actually a normal finding. If she's not alert, she should wake. She should rouse from a sleeping state. If she's not, or she's confused and she's not oriented to person, place, and time, that's a change in level of consciousness and and neurostatus for sure. And we do monitor for the side effect of a cardiac dysrhythmia. Remember, it's an electrolyte, magnesium is, and magnesium and calcium have an inverse relationship to each other. You learned that in your wonderful biochem class. So if we're giving magnesium, it can alter those electrolyte levels, which can then contribute to a dysrhythmia. So oftentimes we will put patients, many facilities protocol is that they're going to be on a tele monitoring as well because of that. So that pretty much sums up the gestational hypertensive client. Be sure you know that your magnesium sulfate, you want to research it, look at your levels, all of those things for your upcoming exams, final exam too, also your NCLEX. And for those of you who are going to be OB nurses someday, that would be super important. What I'd like to jump over for the last 5 minutes is just to kind of move on from some of that normal antepartum stuff, because we still haven't gotten through all of it, and we may not in this video series, and that's okay, but since I have another 4.5 minutes before I'll get cut off, I'd like to talk about fetal assessment. We had left off with slide 38 from your normal antepartum lecture about going back to normal, healthy pregnancies, what fetal assessment, the things we do. And we talked about ultrasound, that's a great way to get a nice little snapshot of what's happening in utero with the neonate, and the care of the mom is a big concern for us nurses, that she should have a full bladder when she heads off for that so we can get great visualization. We also talked about the use of NSTs, non-stress tests, and what it means to have a reactive or a positive NST versus a non-reactive or a negative NST. And what do we do if we have that negative? Well, then we move to the biophysical profile, which is on slide 39. And I actually mentioned it a few minutes ago with monitoring fetal well-being. You know, whether the woman is a complicated pregnancy or a non-complicated pregnancy, if we have concerns that the baby is at risk or the well-being is questionable for a fetus, we can perform a biophysical profile, which is done under ultrasound. And basically it's a scoring system, going back to like the app guys, right? We score a lot in OB, and it's a scoring system of either 0 or 2. And they look at fetal breathing movements, like the act of looking at the fetus breathing, and they should have one every 30 seconds, so they get a 2 if they do that. Gross body movements, there should be some movement of that fetus, at least 3 in 30. So again, they would get a 2. If they don't do that, they don't get 2. And the fetus is always sort of moving. Remember, it's an amniotic fluid. Fetal tone, is the baby flexed? And again, we should see flexion happening at least once in that 30-second snapshot. We do another NST while we're watching the baby. So then we can see movement. Because sometimes, moms are usually really good at feeling their babies move, but if they miss a little bit of movement, we missed an opportunity to correlate that with the acceleration of the heartbeat. So the reactive fetal heart rate, or similar to the NST, would also be observed while the ultrasound is running. And then we look at amniotic fluid. So we need to have at least one pocket of 2 mLs or multiple pockets that equal greater than 5 mLs. So counting those pockets of amniotic fluid, they either meet the criteria or they don't meet the criteria. So, and that tells us that there's still producing amniotic fluid. The membranes are still working, the placenta is still perfusing, and the fetus is still excreting. Because remember, we talked about what contributes to amniotic fluid. So the results of that would be, if the baby's scoring 8 to 10 points, then the baby's fine. Fetal well-being is good. If the baby has anywhere between 4 and 6, we call those equivocal or borderline findings. Doesn't mean we'll do anything, but it does tell us we have to do something more. We can't just not watch this fetus. This fetus could be in trouble. And then finally, if it's 4 or less, then the pregnancy is in trouble and we have to do something. It's an abnormal finding. And with that documentation, we have to have a plan of care, immediate plan of care now. So that's your biophysical profile, which wraps up the prenatal assessment part of normal pregnancy. Next week, we will finish up our normal antepartum with what happens at subsequent prenatal visits. and nutrition and things like that. And then we'll also tackle a few more other complications. Have a great